thanks very much to MQ, and thanks to the committee for inviting me. I'm hoping it might be a kind of the first conversations we start to have about, how do we get all of these great ideas, all of these applications, which I think you're probably all working on or building, how do we get them into clinical care, and how do they become part of the diet of a sort of essentially routine NHS practice to use digital applications, to use epidemiological tools for health resource allocation and sort of decision making and health intelligence. So I'm going to kind of try and peel under the bonnet of how I sort of set up the lab. I'm hoping that this is definitely not, I'd have a tendency of making everything look harder than it probably needs to be. But I wanted if this could be the beginning of a conversation that people can start to have on saying, how are they setting up their clinical pipeline, and actually how to get into the sort of routine diet of clinical care. So as Anna kindly introduced me, I'm a child and adolescent psychiatrist. So this is very much focused towards children and young people, but I think the rules basically apply. So first I want to lead with a thank you, because as probably I think it's been spoken lots of times at these meetings, the technology is a small part of actually what it is to conduct data science and to get certainly data science applications into clinical services. So this is a smorgasbord of different groups representing information governance, system engineering, epidemiology, program managers, trial managers, senior academics, and also some children and young people as well. So I'm very, very grateful for all of them to be able to kind of talk you through what we've set up. So first, just for the audience, most of you probably know this, is that CAMHS is in a dire straits at the moment. It's not got the capacity to meet a fraction of the demand. We've got targets that say if we can really reach 35% of children and young people with a known mental health disorder, our clinical services are operating well. And I think people sort of still balk at that idea. You know, you wouldn't have that in cancer, you wouldn't have that in diabetes, where you say, well, if we meet the needs of 35% of people with diabetes, then we're doing a good job. And currently we've got quite convincing evidence that says that the incidence, certainly of anxiety, depression, is increasing in our children and young people. And it's probably stabilized now, but we're kind of capping it about a sort of nearly a quarter, 1 in 4. And that is actually, so that's population-based studies. On the data on the right-hand side, which is a little bit old, actually just demonstrates that we've gone from 250 cases per 1,000 in terms of referral rates, heading up towards 450 and nearly getting to 500,000 referrals that are coming in on a sort of near monthly basis. So coupled with, we've got a workforce, we've got vacancy rates of about 25% across most CAMHS services. We are crying out for some solutions that can help fix a human resources problem that meets this enormous demand. So people then think, well, what have we got? What's in the armory? And we've got quite a lot of potential tools that we can apply digitally. So this is just a sort of very brief sort of business case overview of what the current problems are. Is that we know in CAMHS services, we don't distribute our care efficiently, we don't make it fair, we tend to there is an inverse care law that we know exists. We haven't got coherent strategies about how to join up our primary and secondary prevention programs. We have limited provision of health intelligence, and I'll talk a little bit about that. I mean, sorry, it's a long list, and I hope it's not too dismal, but it's a long list of problems where we think there may be fixes for. But those fixes, certainly digitally, do have their implementation issues. So currently we don't have a framework really about how do trusts procure and inject digital therapeutic tools or digital assessment tools or informatics tools into practice. We don't really have a good model about how we evaluate harms and benefits from our digital therapeutic tools. We don't really know how to sustain effective products when we've introduced them. We're relying on commercial contracts, and they, as we know, in the digital tech world, commercial provision comes and goes quite readily. We don't have simple systems that we tend to buy stuff off the shelf in terms of NHS products, and we don't really have embedded in our systems innovative process that can change and tweak and adapt in terms of the kind of digital tools that we buy. And overall, and this is what I think this meeting is really also about, is about we still have a kind of, we're still bubbling away at a burgeoning stage in terms of our clinical skills and our digital capacity and developing the next generation of people that are going to be sort of very digitally literate. So here's an existing problem sheet. Sorry, that's a bit dismal. The good news is that we've got quite a lot of digital tools at our disposal, and these aren't particularly unique to our area in South London where I work. These are sort of these are essentially resources that are effectively available for everyone that's working in NHS services. So we all have the potential to use our administrative data, nationally held administrative data, which we can apply for and access and analyse. We all have mostly, certainly in mental health, we have electronic healthcare records, which again hold a huge suite of really rich information and stuff that Rob Stewart, part of DataMind, has also talked at length about, is how we can harness those records for clinical use. And we have a whole list of different sort of found and made data on the left-hand side. We have good analytical processes, mainly borrowing from epidemiological colleagues and increasingly from statistical learning models, etc., that we can apply to those data. And we have quite good things that we've got good reasons to apply them in terms of population management, enhancing precision medicine and support, precision medicine and decision support, etc. The trouble is that how on earth can you get those things in play in order to be able to do things like enhance prevention, increase the availability of treatments, and deliver more efficient care? How do you convince already stretched budgets and business managers in your services to say, look at all these wonderful tools, give me some money, and I'll actually then make something of it? And that was a conversation I had for quite a long time. I really didn't know how to do it. What was useful for me was to start back and talk to business colleagues that say, you need to start really thinking in terms of developing a business model and developing canvases that can be able to kind of tell the story in a more straightforward way, but really think about what your value proposition needs to be in order to get someone to say and pay attention. And those things are often quite simple. And they generally are around saving time, not increasing burden on clinicians, and ideally saving money at the first instance. And if you can demonstrate those things and it leads to not a deficit in care, then you're getting somewhere. So we started with that. That took lots of iterations. And then eventually we rested on some very kind of straightforward things, straightforward problems. The first problem is that we'd be really kind of, which was really loud and clear, and it's quite easy to create a business case around, is that we just weren't getting sufficient data in on being able to track outcomes in our children and young people who came to our services. We didn't know who was really getting better and who was getting worse in our care, would you believe it, in a systematic way. There are mandates that we have to provide that data back into NHS Digital. NHS England remunerates our trusts based on how well those returns are. So we can actually demonstrate if you're not able to meet our collection requirements, that the trust may receive a tariff of about £250,000. So it was trying to find something where there was a sort of clear monetary value, is if you're able to improve the trust performance in a certain area, they would see a kind of return on that investment quite quickly and straightforwardly. So this is just on the left-hand side demonstrates we needed to get routine outcomes. We were getting 8% in terms of our routine outcomes, be able to track a bigger baseline and a follow-up, how children were doing using patient-reported outcome measures. We kind of made a business case to try and find a method of being able to release these patient portals. What crucially is, because we had to get above a 40% benchmark, people create the most delightful portals, but they don't really know how to get people to use them. We were really focused on how to get people to use them. We had to get above this 40% threshold. So we then created these models, which were opt-out models, which the trust actually endorsed because they wanted to get above this 40% threshold. And what that led to was a system called the My Healthy system, which then we managed to get rolled out across CAMHS services. On the left-hand side, you see a graph that basically demonstrates how this automated process is taken over from manual processes. On the orange line is the manual people doing it through paper and pencil collection measures. And on the blue is actually how much this automated process has taken over. And then we've gone from 8% to now local boroughs, so the bar graphs on the right-hand side, to around 45 to 50% of our outcome measures being collected and paired measures. So being able to sort of meet this target that we wanted to get. And it saved thousands of hours. So I think that was just a really simple, quite boring, ultimately, tool that went out, got questionnaires back and information back from families that we ingest into our record, and we could then demonstrate that it was going to provide a return on investment which was immediate rather than a more long-term plan. And because we're able to build that patient experience portal, that data collection method, it then has become a gateway to launching other types of digital therapies, information provision. We can then start doing some stratification, but it really did start with a very simple a quest to try and improve our data collection standards. So, and then the second sort of use case as well, and this is borrowing again from a lot of the work that has been done within our services, and I think within DataMind, to expand the ability to use natural language processing. One of the issues that our trust has, which was quite clear, is that they couldn't really identify who had a diagnosis in their clinical record systems with any accuracy. I mean, that may feel quite profoundly weird, but we couldn't really work out accurately who had a diagnosis of ADHD, for example. The most commonly diagnosed mental health disorder that we provide in CAMHS. On the left-hand side, so we had business intelligence systems that were relying on just purely on our structured data. So we enter in drop-down menus into our electronic healthcare record diagnoses. On the left-hand side is that we had 119 cases on structured records, and I knew in our borough alone that we had far more than that on our review clinic. We had hundreds more. So the difficulty is that we couldn't really clearly specify who was receiving ADHD treatment. We couldn't then build out waiting time initiatives to try and treat those disorders. We couldn't then also make resource allocation requests for increased, for increased, because we couldn't then demonstrate the ratios of clinicians to patients as being sort of so overwhelming, because we just didn't have data to support it. So that within CAMHS was a big issue, because we weren't able to centrally describe who was on these, what the patient journeys were essentially within our services. So using some natural language processing, again, as a balance between the Quality Improvement Centre and colleagues in working in CRIS services, they're able to identify natural language processes going into the free text, identifying those with the diagnosis, and also being able to, importantly, being able to distinguish between hedging diagnoses or negation of diagnoses. So trying to generally be intelligent about how you coded and classified. What that led to was that actually suddenly going from caseloads of 119 to caseloads of 270,000, sorry, caseloads of 2,700. So we were really able to actually, we were only capturing around 10% essentially using these structured diagnoses. I've got 2 minutes left. So the advantage was then that allowed us to push that into dashboards, into clinical dashboards, and then that got the clinicians a bit more interested into the idea that actually some of these data science approaches were actually able to deliver things that they cared about, i.e. decent reflection of their caseload, and increase the trust in the decision-making centrally about what's being used to organise services and to cost services. So what does this really turn into? I've got 2 minutes left. Is that we've divided our portfolio of work into 4 main themes. One is, again, kind of population and clinical analytics, which are sort of touched on, enhanced assessment and therapeutics. And I'm hoping to come back and talk about some of our therapeutic programs, which are being introduced via the My Healthy system to everyone that comes into our CAMHS services. And of course, the education, training and outreach. So how do you train up the clinical workforce to engage in these tools and actually start to think about how to improve them? And then finally, we talk about a later point, which is the data discovery element. Crucially, it has to be bookended by really good co-design and inclusion. So getting children, young people, parents, clinicians, technicians, informaticians, administrators on the ground, all in to try and help shape the delivery of these platforms. And that's why you really get a kind of business case eventually that works, and then buffered by commercial support. And then I think I'm just going to leave this up as a reference. Not that you need to have everyone here that does these roles full time, but if you are building out your lab, it is very helpful to have people that can tap into, have these suite of skills. So you may have part-time people that lend a hand. But I think going from design through to clinical systems leads to have a system engineering, and then someone that can think about novel methods, of analytic methods, are all really helpful in terms of developing your pipeline, whether it be delivering a digital therapeutic or actually just enhancing assessment and the information that you glean from the health records. So I think I'm up. Is that right? And there's a government structure as well, which I'll leave you to. Thank you very much. Thank you.
Oh, thank you, Johnny. Yeah, do come and sit here. I think we've got questions now for a bit. I mean, what really strikes me about this work is that you're really pioneering the kind of first steps towards having a genuinely digitally supported clinical pathway for CAMHS. It's really exciting. So it's kind of what many of us are kind of heading towards, and it feels like you've kind of already taken those first steps. And it kind of really strikes me to think, I've got lots of questions, but one is like, how did you know where to start? What did you prioritize? Was it with clinicians, with managers, with patients? How did you get it going?
Well, with everything really. So at first, it's kind of what was crucial was, I think for us after a while, was to identify where the money is.
Yeah.
So what would people take seriously if you delivered?
Yeah.
And I think the trouble, so for example, with patient experience portals or patient engagement portals, there is still not a clear case in a lot of senior clinicians and managers' minds that they really help.
Yeah.
They can't quite see how that evolves, the type of care that they provide. It's not something that they can report back to in terms of central delivery, i.e. it will reduce waiting time if I can have someone onboarded onto a patient experience portal. So whilst there have been attempts, certainly in our trust and in other trusts, to build these out, I don't think anyone had really convinced the chief financial officers that there was a strong business case to support them.
Yeah.
So I think, the money bit's quite important, but in order to kind of know what's feasible, you have to start talking to clinicians. You have to build up the case around you, and then you have to sort of present some ideas, and then also hear back from the financial teams to say, this is ultimately what we want to deliver on, because we know contractually we have to deliver against it.
And what does it look like in a clinical team that's using one of these tools now? So how do they practically go together?
So the other thing is that the first bit of feedback we always get is, for God's sake, don't make us do any more work. And as you know, the most successful tools that have been that societally been picked up have basically saved time. I mean, that's ultimately what most digital technologies that have been adopted look to do. So I think one of the first things was you've got to introduce something that's going to save time. So we first started with the idea that we had to introduce these systems and automate these systems almost without any clinical hands-on involvement. They can shape the engagement, they can shape the way the things looked, but they ultimately didn't want it to be another tool that was going to distract them away from doing their day job. So that was kind of quite crucial. So we started off essentially doing it all in the background and just letting them know where we were up to. So this was this pipeline that pulls information from a healthcare record, finds sort of a mobile number within the healthcare record, which is not a straightforward thing, uses the mobile number to text a parent, and then they engage on the portal. And that does it for everyone that's referred into CAMHS services. So that was something that we knew we couldn't expect clinicians to be able to drive themselves.
So you're really getting data from the patients now into your electronic health record directly. So it's better quality, reducing time. Presumably better quality because the patients are putting their own data and they know. Is that right?
Well, I think yes, ultimately. I mean, I think the idea was that this was what tended to happen clinically was that parents were just given questionnaires to fill out in waiting rooms. And quite a lot of them got halfway through it. They sort of ran out of steam. I think the idea around outcomes measurement is that it should be a kind of a shared decision-making, information-gathering exercise, but in real life, it wasn't being implemented like that. You weren't sitting over the shoulder saying, "Oh, why have you ticked that item," etc. So it was to be transparent about that and say, these are how these are being used. The other thing was that when questionnaires were being filled out, they were being stockpiled in cupboards, and then being scanned in, and then no one ever looking at them.
Yeah.
So I think I think when you talk about data quality, it has made that data immediately available into the clinical record.
Brilliant, thank you. I'm just wondering if anyone else has got any questions. I could keep talking, but I expect there might be other people who've got questions for Johnny.
Hey.
Couple of questions. Thank you. Dan Robotham from Pin Foundation. Couple of questions from me. So, firstly, well, I'm a parent of a kid who's going through this sort of system of trying to get an ADHD diagnosis at the moment. So I'm aware of how complicated and long-winded it is. So I was wondering about the potential for linkage with sort of primary school education system records, that kind of thing. And the other question, which is kind of related, like in terms of how do you involve carers, parents, guardians, and young people in this process? I've got a bit of experience of doing this with adults, but it's kind of complex and technical. So how do you do it here?
Thanks, Dan. So a couple of questions. So one of the failed attempts I think we had was to see if we could, because we have linked education data and our healthcare record data up. So we can get essentially a primary school profile of kids, and we were interested to see whether we could predict with some accuracy, if you could say from a primary school profile of 3 years, from early years foundation profile all the way through to key stage 2 data, what that said about your risk for developing ADHD. And the machine learning models and the epidemiological basically say you can't, which actually intuitively from a clinician feels quite good, because it feels pretty dreadful just by looking at education records, and absence and attainment, whether you've got high accuracy for an ADHD diagnosis. So in terms of using existing population-based data that are derived from schools, I don't think you can get good diagnostic accuracy on something like ADHD, which does feel like an educational disorder, but you can't really. So you have to start building in proper screening methodologies in schools, and these are using systematically collected questionnaires that you might want to do over a couple of years, and then start to be able to identify and stratify high-risk groups that way, rather than what we currently have, which is a good advocacy system, and it's basically pushing either parents to go down the private system or to be really, really assertive about getting their kids seen, as you're probably going through Dan at the moment, trying to get them seen and try and get them up on the further up on the wait list. And the second question was around engagement, in terms of, well, what's helpful now is that I think people have really bought into you need to include children and young people and parents in your services in a routine way. So in the boroughs that I work in, is that they have a young person's advisory group and they have a parents advisory group, and they sometimes have an external professionals group, teachers, etc. And they've all been pretty good at setting those up. And there's inclusion leads and there's diversity leads within the trust now that supports those types of engagement activities. And we come in and we bolt ourselves into those groups and we say, given the existing services, and what's very helpful about it is that using those, they have an idea about what normal practice is. And then you're able to demonstrate, well, we're going to do this tool, it's going to work in this way. And whilst you might, if you go into some silo groups, they'll say, well, that's an issue because that's basically confidential issue. There's issues around privacy. Parents that are actually part of that process say, yeah, we'd love to engage with something like that. That's really helpful, because sitting there knowing nothing is awful. Having something that we can think at least the trust is still got our referral and still holding on to us, even if it isn't an automated way, at least we've got some receipts, the fact that it's still receiving care. So that really helps us having local representation to be able to almost make the argument about the risks of these systems that you sometimes take to more niche groups actually are counterbalanced by actually the reality on the ground. So so each of the boroughs that we work with have their own already set up children and young people's groups, which we basically engage with.
Brilliant, thank you. I'm aware of time, so I think actually we might have to end this session there. Am I right about that? We can take another question. Oh, brilliant. I thought there was another hand that I saw in this over here. No? Oh, there, thank you. Oh, brilliant. Oh, I think you might need the microphone.
Yeah.
Sorry. So you talked about the natural language processing project, and I just wondered, was that specifically in SLAM or was that national CAMHS services? I guess if it was just in SLAM, how easy would it be to scale up?
Well, I might actually ask Rob around to talk about scaling NLP pipelines. My understanding is that there was the technology in terms of it pushing it over to free text, as long as you've got someone that basically understands those pipelines. I think is not that hard now. The hard bit is getting all the agreements and the governance arrangements and making sure someone's happy for those pipelines to be set up and processed. And that's mainly around understanding rather than real risks, I think. Is that fair to say?
I think Rob would be better at answering this.
Oh, Rob, sorry, yeah.
But one of the things that I would say is that in some ways it's similar to all the coding stuff. It's making sure these things are discoverable for use in other systems, because they're not connected in any real way across nations or within regions of the UK. And that's definitely where data might sit. Rob leads the road builder on this, so he'll probably have something to say.
Go on, Rob.
Sorry.
Yeah, why do I get the feeling everyone's passing the buck here? No, I think there's things to be. The difficulty is we don't have enough case studies around where we're doing this. I think you make it happen and it'll happen, and we just need to figure out a way of sort of delivering these things. I mean, for something that's a live pipeline, clearly that's a slightly different. I mean, what we've tried to do at the South London and Maudsley is make our apps available through a sort of interface that we've just recently developed that was part of the sort of data mined road builder and a service to support that. But I mean, where you're talking about sort of live processing of data, then that I guess involves kind of working with whatever company is putting those pipelines in place, because someone has to do the engineering of the pipelines, and then it ought to be fairly simple just to kind of put in the code in amongst that, really. So it's just there hasn't been enough. We just need to kind of get something going and figure out a way of doing it that works.
But Rob, my understanding is that the technological constraints they're not the real constraints ultimately.
No, I think it's more boring things like sort of who's going to do it and the engineering side of things, and getting over that hurdle, which often is slightly. Because trusts don't have their in-house engineering services, it's sort of, it's complicated because it may involve some commercial third party, and then, so it's just, but all these things are fixable, with just getting a few people in a room together to work out how to fix it. It's just getting over those hurdles, I think.
Making a business case.
Brilliant. Thank you. I think I've had the nod, so I think we've run out of time now. But I just want to say thank you, Johnny, and we're excited to see the next stages as it evolves. That's great.
Cheers.
Thank you.